Hi, it's Jeff Worrall here. I think we're 2 minutes over now, and while there's still people joining, I think we'll start. As you can see, if you can see me on the video, I'm holed up at home at the moment in semi-darkness because it's quite a small and cold room. So I've got my jumper on, even though it's supposed to be summer. Anyway, so welcome to this event. We've been running a few of these events over the last couple of weeks, so very successfully. So hopefully this will be a really inspiring event to share with you some good practice across the Midlands. I know I'm seeing people joining from all over England, so it's really great and welcome to the Midlands. And just a couple of things on housekeeping before. And I won't be long. I'll introduce Ian Sturgis, who'll be more interested than I will be. On housekeeping, just make sure you're on mute and your camera turned off on Teams, unless you're a speaker. All other phones on mute as well, because we don't want any interruptions. And please use the comment function to make comments and raise potential questions. So using the chat column, that's a really we're all getting used to NHS and Microsoft Teams now, and using the chat line is really important way of actually getting a conversation going. So that's really helpful. Next slide. So each Acute Trust has been given the opportunity to share their experiences in managing through COVID. This has been a tragic for lots of families and people, but it's also been a real challenge in terms of how we deliver services, particularly the segregation of patients and the need for shielded patients and self-isolation and 2-meter distances in that response have created a huge strain. We had an excellent response from people, and with a wealth of information gathered, and this event is to share some of those experiences you've had. So this workshop or webinar is built on the experiences that people have actually put forward in terms of the way they've managed things. So, and hopefully this will give you how to address challenges yourself or contribute yourselves in terms of further ideas. So the key themes that have emerged from the discussions is around the challenge of restoration, about recognising that the patients are starting to come back and how to actually manage them, because we did see a significant drop through the COVID period. Dealing with the uncertainty of things to come, things like dealing with COVID and non-COVID presentations and query COVID patients, and how you actually protect staff and protect patients in that environment, and the challenges of actually departments and units which really haven't got sufficient room to actually provide the distance you require between patients and between staff. There's a whole issue about staff interacting with each other and infections passing between staff. We have selected our speakers with these themes in mind, and I'll just put up a couple of slides very briefly just to give you a to show what's happening in the Midlands in terms of the size of change. So the first one is A&E activity over the period from 1st of February to the 23rd of May, and this will be mirrored across the country. You see the dramatic drop in attendances, type 1 attendances in the Midlands. The most significantly, the drop was in the minors, but there was still a major drop in majors, which is starting to recover. The minors is much slower to recover. Can I have the next slide? The next slide is again showing paediatrics, and paediatrics has fallen away significantly, and then the road and resource has also fallen away. And I think there's a really good article a few weeks ago in the HSJ by Dr. Ben Owens, who's one of the clinicians that works with us, and also the lead clinician in Sherwood Forest hospitals, which works through why we've seen such a pattern of attendances. And as you can see, the last one is about the occupied bed days, which remains significantly down from where it would have been last year. And next slide. And finally, this is the ambulance activity in West Midlands and East Midlands. And as you can see, there's it's remained closer to the previous year, and I think that's a reflection of both the COVID work and the non-COVID work. And I certainly understand that certainly more recently there's more been a growth in the activity, the non-COVID activity, as lockdown has been eased. So I didn't really say it any more. This was just an important way of actually just setting the scene for this webinar. And I'll now hand over to Ian Sturgis, who will talk about frailty and what COVID has taught us. Thanks, Ian. I'll leave it to you.
Thanks, Jeff, and thanks for the introduction. I hope I am more interesting than you. I didn't mean that in any negative way. So, yeah, thanks for everybody for joining. I'm the Urgent Emergency Care Clinical Lead for Frailty for the Midlands region. I just wanted to share with you some high-level themes. We've only got a few minutes about some of the conversations that we're having using our key lines of inquiry process, and then the event that we actually ran at the end of April, where people were systems were sharing. And I'm talking about systems, not organisations. We asked it for systems sharing rather than organisational sharing. So can I have the next slide, please? No, one before. Gone one too far. That's the one. Just to show that the number of organisations that joined the seminar at the end of April was quite considerable. It wasn't just the Midlands region; it was the length and breadth of the of England, and we had well over 100 attendees and quite a lively conversation going on at the time. And I think that was really important. There was really honest sharing from the 8 systems that. Of the 11 that we've got in the Midlands region, who put up to share their what had gone well and what had not gone so well, and also what ongoing support they needed in the future, about how they were planning for the next phase. So it really was a lively event. We had a couple of speakers, an opening speaker and a closing speaker. A closing speaker was Bola from the national perspective, which was really stimulating as well. So it was a really lively event, and all I can really share with you are some of the high-level themes. I can't really go into the full detail of everything that we discussed, but just show some of the high-level themes. So can I have the next slide, please? Can I have the next slide, please? Lauren, I haven't got the next slide up.
Ian, we have. I think there might be a delay on your system.
Okay, I will. Right, there we go. So what has gone well? So really what people were saying is that they were learning as they went along. And actually there was a lot of shared learning across systems. And people were learning together, which was really quite powerful from what people were talking about. And I'm just going to go through the things that have gone well in just 3 sort of general headings. Level of integration that occurred was the fastest that people have ever seen. It wasn't complete integration, but it was some of the fastest I've ever seen. And the way that barriers were removed was really, really insightful for people to see how things could be done at pace. What was also really clear was this was a truly clinically driven process. Clinicians were at the very heart of the change programme, and they were being effectively supported by their managerial colleagues and their executive colleagues to bring about the changes across systems. So it was really, really powerful for clinicians to be involved in this. And one of the comments that came from many of the clinicians was, please may this continue into the future rather than going back into our organisational silos, to make sure that actually this is clinically driven processes. And finance was seen as an enabler rather than an inhibitor across this integration. Finance was not putting up barriers, was actually seen as a real enabler to bring about the change that needed to take place. Obviously, we all know that everything didn't work perfectly, but people were learning as they were going along. The second heading really was around innovation. One of the things really was virtual access to clinical decision makers, be that GPs to consultants, or ambulance service from care homes to consultants, to get rapid decision making about older people living with frailty with an acute event, whether that was an acute COVID event or an acute non-COVID illness. It was really helpful to have that virtual access to clinical decision makers. And where alternative care pathways were not either in place or not fully implemented, what was really refreshing for people to see, not universally but across many systems, was the rapidity of delivering alternative pathways and the really supportive process from end-of-life care, particularly from the palliative care teams. And I really want to take my hat off to the palliative care teams around the regions. They really stepped up and supported the frailty process really very effectively. Care home support, there were some interesting innovations, but this was variable across the region. But there was one or two really positive things that, and care homes were saying that they felt supported. The final thing about what had gone well was relationships and trust. Mostly positive. There were some challenges which need a real focus in the future, and that's in the broader context. I think that's a national picture around care homes and care support in the community. There was some felt that they were left on their own devices to a certain extent, but obviously that's picked up in the recent past. What really helped build the relationships and trust was this was a real unifying purpose which created real alignment across organisations. There was a real recognition that this at-risk group of patients, people living with frailty, were at risk of exposure to COVID-19. So if they could be managed in a safe way without having to attend hospital, that was really what people wanted to achieve. And if they did have to go to hospital, how could we get the patients home as quickly as possible, whether they had a COVID or a non-COVID acute illness. So really, for this group of patients, because of their clear risk from COVID-19, created a unifying purpose across systems. Next slide, please. I'm going to read it from my own slides because it's not come up on my. So what have been the challenges? I've already alluded to one, care homes and the care sector. And this was multifactorial. This was both provision of clinical support. And I would reflect that this is actually something that's been going on for a long time, that sometimes the care homes and particularly care sector feel sometimes a little bit outside of the NHS and feel somewhat disengaged, as it were. I mean, I know some regions around the country, well, some areas around the country, district nurses won't go into nursing homes because they say they've got nursing support. Well, actually, they won't have those skill sets that district nursing have. So I think it is important that we build on how do we provide effective clinical support to the care homes and to the care sector in people's own homes as well. Infection control advice was variable. We all know about the provision of PPE and also the ongoing still challenges around getting effective testing, because I am concerned, I'm sure all of you are concerned, that care homes may be becoming a seeding of COVID out into the community by a number of people moving in and out of those care homes. What was really disconcerting and really not disconcerting, really challenging, and a real needs to be a real focus for the future, was provision of data and clinical information flows across systems. It really highlights the lack of integration of data and also the single electronic patient record across systems. The spine is not sufficient. You need real live information sharing. And I've always said this in my talks on urgent emergency care, that if you want to convert the unheralded into this relatively heralded, you have availability of all information, clinical information to clinical teams, whether that's within the primary care sector, secondary sector, be that acute or community, and etc. And ideally sharing as much as possible with the social care sector as well, and vice versa. One of the real challenges about the provision of data was the inability to track impact on the system and specifically outcomes for patients. We saw a very significant fall off in older people living with frailty presenting to hospital, and obviously we had very rapid discharges of these patients. But what we don't have is a very clear picture of their outcomes and the impact across the system. And that's something that's really got to be looked at into the future. There was one or two issues around confusing contradictory advice from the centre, but everybody recognised that this was a very fast-moving piece, and the advice had to change pretty rapidly at times. One thing that was particularly relevant for one organisation who had embedded the Edmonton scale in their frailty scoring system, they feel a little bit nose put out of joint, being almost forced, as it were, or challenged to implement the clinical frailty scale. And I think, you know, if you've got a scale that's working well across your system, you wouldn't want to change it. Next slide, please. And again, I'll go to my own slide so I can see what the next slide was going to be. This was about the near future, what is needed. Obviously, the crucial thing is keep what has worked well. I mean, I think, you know, where rapid response has worked well, where early supported discharge has worked well, with the proviso around outcomes data, which is absolutely crucial. We've got to keep that going and keep that integration, level of integration. We've got to avoid going back into organisational silos. This is absolutely crucial for older people living with frailty, both in the health promotion and health prevention side of things, as well as the urgent emergency care pathway, which is a short interlude in many patients' ongoing journeys. I think it's important that we do maintain a focus on frailty. One of my challenges around the cells set up across nationally was that they didn't actually fit well with frailty, which actually sits across all the cells. We've got to make sure there is a focus on frailty. I know there's a lot of talk now about the challenges facing patients who may have cancer, and I think that's a real concern. But I also counter that with some of the shroud waving I've been seeing around cardiovascular mortality, myocardial infarctions. I think it actually highlights that we were probably doing too much in the way of interventions. And what I wouldn't want to see is both cancer and cardiac escalating and moving frailty to one side. I think frailty needs to be front and centre as we move forward, as we move through a second phase, which I think we've just got to assume is going to happen, as well as a third and fourth phase as happened in the Spanish flu pandemic in 1918. Crucial thing, as I think is absolutely crucial, we got to focus on outcomes. And if people aren't getting the data on their outcomes for their patients who've either had older people living with frailty, have either been managed through an alternative pathway without having to go up to hospital, or who've been managed by a rapid discharge pathway, it's crucial that we have outcome data, be that at the patient level, that's functional outcomes, so the avoidance of hospital-acquired functional decline, level, how we to understand about this week around managing delirium in patients with COVID-19. And also then finally at the system level, what are we achieving in target populations outcomes? So older people living with frailty, what are the population outcomes, what are the costs of this care, and what's the experience of care? And I think that crucially, we've got to have a real focus on effective clinical support to the care sector and to care homes. I think this needs to be much more robust. So if we can move on to the next slide, please.
Ian, can I just give you a 1 minute warning there as well? Sorry.
Yeah, this is the last slide. And I think really the near future, what is needed is actually written in the NHS long-term plan, the Ageing Well strategy as well. We've got to make sure that urgent community response is more robust, that we have the 2-hour response time, as well as the rapid response, as well as the early supported discharge. We need enhanced healthcare into healthcare support into care homes, as well as and also into patients receiving care support, and also better planning for anticipatory care. It's not just about advanced care planning and end-of-life care planning. It's about true anticipatory care planning, so that we actually mobilise the support going into the community for those patients, appropriately avoiding their attendance at hospital. And these were the major themes that came out of our event. Thank you.
Thanks, Ian. That's really helpful. And I think it's really important just to raise, as a Midlands region, frailty is and will continue to be one of our absolute priorities. We totally recognise the need not to place these patients in places where they're not getting the appropriate levels of care. I think that was a really good roundup. So huge support for that piece of work, and thank you. One of the other events we've also held was around the EDs and what the learning has been from the ED forum. So Jim, the second time this week, so apologies if there is a little bit of repetition for those of you that joined us yesterday. It's kindly going to talk us through what we learned from the ED Clinical Leaders Forum around COVID-19 and moving forward. So over to you. Thanks, Jim.
Charlotte, thank you very much. So yes, severe apologies to anyone who's seen these slides. You'll see slightly fewer of the slides than there were yesterday because I ended up having to speak very, very quickly. Thank you very much. I'm an ED consultant in Coventry. I'm also the regional clinical advisor for emergency medicine in the region, and we ran a similar event. We ran an event that was warmed up really by Ian in the preceding days and that then followed on. And next slide, please. And this event really was sort of, I suppose, a step in the pathway of trying new stuff, working out what worked, what didn't work. And this was really a reflective piece. It was a piece really trying to examine the bits that had been successes and people would want to carry on with, and the bits that we realised that we never want to touch again and we want to leave well be, knowing that this is going to be a real journey. This is going to be a real process of evaluating the good and the bad and the experience that has been this COVID response. Next slide, please. So we had a great event. We were represented by 7 trusts from across this was not done on a system level, but it was on an acute trust level, with keynote speech from Catherine Henson, who's the RChem president, and Cliff Mann, the national clinical director for emergency medicine. So a really good afternoon. Next slide, attended by a huge number of organisations from across the patch and across the country. I think we had about 150 delegates attending, slightly over. Disappointingly, the 999 event yesterday did slightly better than that, but it's not a competition. I think there's learning for all of us. Next slide, please. One of the things we really realised was that the Midlands is fairly unusual. The Midlands has been unusual in that we've had a really heterogeneous spread of the impact of COVID disease across a number of different sites. So we have some huge metropolitan university hospital type sites through to some very, very small, very rural, very complicated mixed sites across wide geographies, which, although may be represented in other regions, they don't have this odd split of impact of COVID disease that we've seen. So it meant that actually learning from the clinicians delivering care on the ground was really beneficial for us, and we had a number of different stories to tell. And valuing each of those stories, one of our speakers was very concerned that as a representative of a smaller site that had been less impacted perhaps than some of the others, that their voice wasn't important, but actually it really was, because the truth is that there hasn't been one version of COVID for all of our organisations. It's been different for some of them, and we need to understand that so that we don't enforce a blanket change that will impact some positively and some negatively. Next slide, please. So the positive learning, and there was a huge amount of positive learning, and these are loosely weighted. So the higher up on this list they are, the more representative of a larger number of systems reporting this is how this sort of plays through. And the teams really felt that the ability to change systems at significant pace was something that none of us had ever really seen before. All of us have experienced the hardship and the complexity of trying to change systems in a healthcare setting. And I think we all know that it's not usually a speedy thing. And this was unusual. So there was a huge amount of system change, done at a huge amount of pace, and generally very successfully. All of the sites, I think, were joined together and say that the ability to flow patients through an emergency department has revolutionised how those emergency departments feel and how they feel they're able to deliver care, and they would be absolutely unanimous in saying that they felt that they were able to deliver better ED care in a hospital that has flow through its emergency departments than one that doesn't. Communication generally, both within organisations, across departments and between organisations, has been vastly improved. Now, some of that is simply because we've moved to a single issue set of communications. We're trying to deal predominantly with one problem at a time, rather than with the myriad of things that we're all trying to do out of this COVID period. But it was reflected on by so many of our departments that they felt that the ability to communicate both with their own staff using new and novel techniques, but within their organisations, was vastly improved. Almost everyone felt remarkably supported by their estates department, and the variety of approaches to delivering barriers in one form or another, or dividing departments in many complicated ways, really has been really good, and people are very grateful for that. In the main part, where we've removed activity from an emergency department and relocated that, particularly where the separation of the minor stream has come out of an ED and been sourced somewhere else in the hospital or to another site, has worked well. And I think that all of the EDs that fed back on those pieces of information said that actually they were work streams that sat well separate from from an ambulance borne or from a more majors driven emergency department, perhaps in ways that they hadn't anticipated beforehand. Departments felt that senior decision makers were permitted to make early decisions on patients, and some of this flows back into the ability to flow patients out. And all of those organisations who perhaps either have implemented or have considered implementing very early senior decision makers in a patient pathway, that's far more successful when patients are then able to move out of an ED, be that to a respiratory area, be that to other parts of the organisation based on surgical pathologies, gynae pathologies or medical pathologies, by where that senior decision making is acting a streaming decision as opposed to a pre-ED assessment decision. That was certainly valued by those. And lots of sites talked about the mental health step up and the fact that mental health services were supporting their EDs perhaps in a way that they may have struggled with in the past, and that had become a more joined up service in a lot of ways. Next slide, please. So then that brought us to the other side of this, which was, well, what was the learning that was less well received? And there was some, and there were some difficulties, and certainly the key that people reported back was problems with flow out of departments. Although we've had a period where hospital occupancy has been in its lowest levels that any of us will remember for many years, and yet we were still experiencing times when patients were being cohorted in EDs or being held in EDs. And across our region, we've still seen a number of sites who've had patients in the ED footprint for certainly 8 and up to 12 and beyond 12 hours, despite the fact that we've been running a hospital bed availability and a hospital ITU availability, the likes of which we haven't seen in modern times. And so some of our processes around flowing patients out haven't always worked quite as well as perhaps we might have liked. Some smaller sites, and again, we're a region of many flavours, and some of our departments are very modern and are world class in terms of their ED footprints, and some are older and struggle with much smaller departments. And dividing the footprint of some of those real estates proved to be really quite complicated. And although the estates have been widely praised, actually the footprint for some of those regions has been really struggling.
Jim, can I just give you a 1 minute warning, thanks?
Yeah, I can. I will speed up a little bit. Certainly that ED footprint has caused some a problem. And then the final two really sort of sit together, which is I think there's a real push to move to the restoration of services. And for a lot of inpatient specialties, that means pushing back to an old normal approach. Next slide, please. This is something that we'll skim over relatively quickly. It's the Royal Society of Arts approach to what do we keep, what do we don't keep. Interestingly, our negative learning, a lot of those fit into none of these boxes. They're things that we did, but we didn't do brilliantly, rather than things we stood up or things we stood down. Next slide, please. So we also asked departments what they would want help with in the future, and they came up with this list, which is help to focus on change for improvement, not returning to old ways of working, protecting staff, protecting patients, particularly shielded patients or higher risk patients. Maintaining alternative pathways where they've been demonstrated to be successful, even though they may be at odds with the service that was previously delivering them. And working together with the 9s and the 1s services to join the system together. Now, interestingly, next slide, please. A lot of those, particularly the staff and patients protection, fit in with the RChem recommendations and their push to ensure that EDs don't become sites where patients, particularly shielded patients, acquire COVID or other infectious pathology infections because of crowding or because of crowding within the hospitals. And one of the impacts of crowding either in an emergency department is then the knock-on to crowding on the back of ambulances, because the days of bringing patients off an ambulance to queue them in an emergency department looks like it can't be allowed to return. And what we can't do is then just hold patients on the back of ambulances, because we consider that to be the next safest thing. Next slide, please. And then it also fits into the thinking around how 111 will take an enhanced role in either heralding patients into an emergency department setting for the group that have contacted them first, or directing them through a much enhanced clinical response and directory of service into other pathways rather than relying on an ED catch-all for anything that doesn't fit into the more straightforward pathways that existed beforehand. And final slide. And within our emergent department, we'll need to look to capturing how these heralded and unheralded patients are dealt with and cared for, particularly how shielded patients can be received into hospitals. And I know that a number of sites are starting to think about how we can really make sure that shielded patients are protected as they come through our emergency services. And then how patients can flow out, and people will have started to hopefully have heard talk about cohorted post-ED or pre-admissions units to ensure that the EDs don't become congested, so that we're not either holding patients outside, queued up in 2-metre lines down pavements, or in the back of ambulances. So a really good event, hopefully some things that will be of interest and will resonate with you listening, and thank you very much.
Thanks, Jim. And I think it's there's some questions for you in the chat. I also think it's really great to hear about that pace of change and that ability to really make service changes when normally it would take us forever, and we've managed them overnight. And after Marion, our next speaker, spoke, and we're going to look at some of those amazing changes that some of you have been making on your site. So we'll come into that in a second. But Marion's very kindly joined us nationally, because we're aware there's not just Midlands representatives on this call, there are people from across all of the regions, and she's agreed to kindly cut this a little bit shorter for us in the interest of time, to give us a whistle-stop tour of some of the work that the national team had to do to adopt their stance during the incident. So Marion, thank you for joining us.
Thanks, Charlotte, and thanks everyone. So obviously there is a lot of work going on nationally to look at lessons learned, but that work is not yet complete, and therefore I'm not able to at this stage give you a lessons learned from a national perspective, but I'm sure that will come out to you shortly. So I thought what I would do today very quickly is just briefly talk about some of the challenges that the National UEC Ops team went through as a result of coronavirus. And I'm sure that there will be some things here that you can relate to. If we just go on to the next slide, and I'm just going to touch briefly on the function, health and well-being, and then what we learned. So we'll just do a quick canter through onto the next slide. So the UEC Ops team is a well-established team. We are probably a team that people love to hate, because we're constantly asking for more information and annoying the regions on a regular basis. However, we are well-established, and we had up until the beginning of the COVID outbreak a very clear remit. We had an established daily battle rhythm. We had a shared culture, we'd established relationships, and there's only 8 of us in the team situated in Skipton House. We were able to build relationships very easily, and we were happy to go about our business. And then coronavirus hit and the lockdown came, and the picture on the right of your screen is no exaggeration to how it actually felt. We had been a 7-day service over winter, so we were well used to working from home at the weekends. We assumed that it would be fine for us all to work remotely. We had not anticipated the challenges that were going to be attached to that. Our remit changed very quickly from one day to the next. We found ourselves in fact, 2 weeks into the lockdown, that performance started to improve. And certainly by the middle of April, we'd seen performance above 90%, something that we hadn't seen for a long, long time. And then it was sustained. We saw the ambulance services, although they had challenges with personnel and resource, we saw that their performance from a handover perspective had improved significantly, and all of a sudden we felt as if we had nothing to do from an overview and surveillance point of view. Then we had the shift to the ICCs at regional level, and so that took away completely our established relationships with the regions, and we had to try and very quickly establish new relationships through the ICC and find a new way of working. I think that had been, we underestimated just how difficult that was going to be. We had just gone through a recruitment process. We had some new members of the team. And again, although they were established ops people, we underestimated how difficult that would be for them and the impact that all of this would have on our productivity. One of the big changes was the amount of requests, ad hoc requests, that were being received from just about every direction possible for information, for reports, for some analysis, and that was just created such chaos. I think we underestimate the importance of being co-located when you are trying to establish a new way of working, and certainly for us that was one of the big learning from this. If you just go on to the next slide, I think from a health and well-being, if you look at this slide, I think every time I look at it, and when I look at it over time, I get something new from it. But we were still all had a common purpose, but although we were connected with teams, we were still isolated. And I think the impact of that on us as a team, but also as individuals, was started to be felt certainly very quickly into the lockdown. And again, I think that we underestimated the need for that pastoral care for the team members, some of whom were struggling more than others. And I think if we just go on to the next slide quickly, we'll just move on. What we've learned, I think, expect the unexpected, be prepared to reprioritize, often even throughout the same day. The deadlines for reports were hours rather than days. We had to try and understand what capacity there was within the team, and sometimes regroup 5-6 times during the day to try and reorganize. And that is very difficult when you are not together in the same place. I think understand individual resilience. I don't assume that everyone is coping in the same way as you are. For those of you who know me, I'm very much a get on with it person, and I've had to be reminded on several occasions that actually not everybody copes in the same way, and I certainly have learned a lot about this during this period. And again, some of that has been reflected in the way the team has been able to deliver and to prioritize work. Touch points in the day, rather than having more, rather than fewer, because it was so busy, it was felt that we should just have a beginning of the day and an end of a day touch point. And in fact, what we should have done is put more touch points in, because I think that would have helped in terms of how people were feeling and the support that people felt that they were getting. Give permission for time out. I think that it is so full on. I think we've learned that it is important for people to be able to say, do you know what, I just need a break, and to be able to respect that, and that break isn't just a tea break, but sometimes can be something a bit more than that. The other thing is we dropped all social activities, and I don't think, again, we realise how important some of those events are for helping us to just sort of just cope. They're coping mechanisms, whether it's the drink on a Thursday evening after work with our work colleagues, or it's going to the football match, or it's going to the theatre. All of those things were taken away overnight, really, from us. And again, I think that we needed to be a bit more aware of the need for some of those social activities within the work calendar. And I think, again, the being kind to everyone. I think, again, this, kindness goes a long way. And I think we find that during this period of time, it is so important, despite the pressures that we're under, that we do find a way of being kind to everyone. And I know that we are very far away from the front line, and very conscious of the fact that we're a small part of of the NHS. However, I do think that some of the experiences that we have gone through, I am very sure that these can be reflected in other teams and in other situations. And I just have really valued the having the people around me to be able to get through it. And I do hope that we can carry on learning as we go through this, because I am sure that we're going to be working like this for quite some time to come in the future. Thank you. Thank you.
Thanks, Marion. That was fantastic. It's actually just put shivers down my spine seeing that picture of all those people sat so distanced in that hall, and it just makes you realise the human factor to what we've all been through, which is key, and actually has put an absolutely fantastic link into our next two speakers. So I'm really grateful that Northampton have put two presentations together for us today. The first focuses on patients and their family, and the second on their staff. And I guess never was more three groups of individuals more important through what we've been through. So I'm going to hand over to Rachel, who's going to talk about patients and family, and then Moya is going to follow on around staff from Northampton. So thank you very much.
Hello, everybody. So I'm Rachel Livesey. I'm the Head of Patient Experience and Engagement at Northampton General Hospital, and I'm going to talk with you today about how we have tried really hard to keep patients and relatives connected during the pandemic. Have the next slide, please. So the main issue that we faced really was when we stopped visiting. I mean, it made total sense, obviously, to put this into place because we needed to keep people safe. However, when we start considering patient-centred care and all the things that we know around how patients need to be supported, if we look at the PICA pyramid, we can see that involvement of family and friends is so critical to patient-centred care. We knew we were going to struggle with this. We knew that patients were going to start to feel lonely and isolated, and obviously as well communicating with relatives, because obviously we're not going to have those face-to-face interactions anymore. What kind of impact would that then have on people phoning the wards and the pressure then that would create? And obviously it's scary knowing that your loved one is in hospital and you can't do anything. So can I have the next slide, please? So basically, my team, patient experience team, the volunteer service, and we have a head of volunteers and also our head of PALS and complaints. We all considered different ways that we could try and support people and to keep patients connected with their families, and that's what I'm going to talk to you about today. So the main ones that we've done are a relatives helpline, a patient property drop-off, patient video calls, letters to loved ones, and our connected heart. So I'm just going to try as quickly as I can to talk you through all of those now. The next slide, please. So our relatives helpline was set up by our PALS and complaints team. Obviously, when we knew that the pandemic was kind of on its way as such, we knew that we weren't going to be able to investigate complaints in the same way that we have been, because we simply wouldn't have the clinical team's attention to be able to give to it. So they considered different ways of working. One thing that they initiated was a relatives helpline. And obviously this gives the ability for relatives to call and find out information about their loved ones in hospital. It then takes the pressure obviously off of the wards themselves, because they're not having that constant phone ringing when people can't get through, ringing and ringing over and over. So this runs 7 days a week. And as you can see from the numbers, it's been very heavily used. To date, we've had 3,924 phone calls to that helpline, averaging 436 a week, which is 62 calls a day. Now, if we consider that volume of calls going to the wards themselves, and if we consider that there probably wouldn't be the person to pick up the call on at the other end on a ward, that is quite significant numbers, really. Okay, the next slide, please. So another thing that we've done as well is our property drop-off, because again, if you're not having visitors come in, who's bringing you bits and pieces when you come into hospital as an emergency? And obviously that can be really distressing to not have even things like phone chargers or some clean underwear, these bits and pieces that just make us feel that little bit more comfortable. So we set up a drop-off service And that's actually run by our responder volunteers, of which we recruited 130 of them, which has just been amazing. And this runs 5 days a week from 9:30 till 2:30. And we encourage relatives to include a letter as well within the belongings that they can then give to their loved one. Delivered the same day, and again, heavily used, averaging 130 items of property every single week coming through that property drop-off. And again, this was something that was rolled out within 5 days of visiting being stopped. So that's been really positive. Okay, next one, please. Gosh, this is a bit of a busy slide. So probably one of our most successful things that we've rolled out is our patient video calls. Again, we wanted to consider ways that we could do virtual visiting, which I know is what a number of hospitals are calling it. So we used old stock iPads and iPods that were used for things like Vital Pack that had since been updated. And the IT configured them and added things like Zoom and entertainment apps as well to try and alleviate boredom. So they weren't just for video calls. Actually, we got the first 4 iPads onto wards that didn't have bedside TVs within 2 days of visiting being stopped. We basically made staff and patient guides to go with them. Infection prevention helped us on how to clean them. We got everything out there really quickly because we were really concerned about the detrimental impact on patients' well-being when we stopped visitors. So this has been expanded, and we now have tablets donated through our charity. We have over 70 devices now available within the hospital. Every ward has at least one, and some wards have up to 6 within there, particularly wards that don't have the bedside TVs because they're meant to be short stay wards. But this is where it's really come to life with the response volunteers, because they have enhanced this now by actually coordinating a 7-day-a-week facilitation of video calls. So previously, obviously, we would rely on the ward staff helping. Again, they are so busy. So the volunteers are actually doing this now. They're going onto the wards and facilitating this. So to date, since the 26th of April, which is when they started, they have facilitated 360 video calls, which I just think is fantastic. And that includes people that live abroad that can't be with loved ones. And they've even supported patients in dialing in to watch funerals, which is incredibly sad, but I know means a lot to people to actually be able to be present in some way. So yeah, that's been really positive, the volunteers actually taking that on. So while the wards do facilitate some, the most are probably facilitated now through the volunteer service. Okay, next slide, please. Oh, well, I won't go through that, but when you guys get the slides, just have a read of some of the feedback that we've had on this, because it's lovely and it really brings it to life. But I won't read that out right now. Thank you. So another thing that we've done, again, utilising as much technology as we can possibly manage, is our letters to loved ones. We've set up a bespoke email address, and we basically encourage relatives, friends, family members, I mean, literally anybody that wants to write into their loved one and send photos or a letter, basically. So the patient experience team during the week, we print them, envelope them, and then the volunteers do it at the weekend, and then the volunteers actually deliver the letters twice a day. Again, the volunteers providing an amazing service through this, but we just wouldn't be able to provide on our own.
Rachel, sorry, I just need to give you a 1-minute warning.
Yeah, absolutely, no worries. Okay, so they've also expanded this to include a text number, a dictation service where people ring and they'll literally type their letter up for them, and a readout service at patients' bedsides as well, which has been great. And to date, 910 emails have been received. So if we start adding up all those numbers of the amount of calls received, the amount of emails received, the amount of patient property being dropped off, you know, we're seeing some significant interactions here. Again, there's some feedback there, but you can read that in your own time. Can I have the next slide, please? And this is probably the saddest part, but again, we're trying to keep people connected with their loved ones. Relatives can't always be with their loved ones when they pass away. They might be poorly themselves, they might be shielding, or they simply live away and can't get there. So what we've done is we've got identical hearts that are handmade by a member of the public. And then when a patient passes away, one of the hearts is placed into the hand of the patient that has died, and the other is given to the loved one with a special card that has some lovely words on it. All of these packs are handmade by my team. We don't knit them, unfortunately. Our skills lie elsewhere. But yeah, we make up the actual packs, and now every single ward has this. And we've been in touch with funeral directors in the mortuary to make sure that they're handled well, and this has been really successful as well. Okay, next slide, please. So our lessons learned. Technology is your friend. It can seem scary, but actually, once you kind of dive in there, there's so many ways that you can keep people connected through technology. Providing multiple ways for people to contact each other ensures you kind of offer something for everyone, you know, whether it's including a handwritten letter with someone's property, or sending an email, calling, video calling, so many different ways. This is a big one, and I know someone mentioned this before. Things don't have to take ages to roll out. You can take some calculated risks with these things. You know, normally we'd be like, right, you've got to do a SOP, it's going to have to go through this, it's got to do that. We just did it. We just took the risk because it was worth it, because we knew we needed to. I can't big up the volunteer service enough through this. They have been amazing. And again, myself and my 2 members of team could never have kept these things going in the way that they have. We can roll it out, we can project manage, but we are not feet on the ground. There's not enough of us. So the volunteers have been great. And I know this is much easy, but I don't care. Teamwork makes the dream work. Pulling all of those services together has been such a success for us. And last slide. That's me, and that's my head of volunteers as well. So if you want any more information from us, then please get in touch, and we'd be more than willing to share. Thank you.
Rachel, thank you so much. And I feel terrible I don't actually have enough time to properly praise what is clearly an amazing piece of work that is going to remain in people's hearts for a long, long time to come. So thank you, and I'm sure you'll have lots of interest on the chat from that presentation. Moya also joins us from Northampton. Tough act to follow there, I'm afraid, but I'm really looking forward to the work you did with your staff as well. Thank you.
Thanks, Charlotte. So good afternoon, my name is Moya, and I'm going to tell you how Vicky and I have led the team that is supporting the psychological wellbeing of our staff during this pandemic. I need to give a quick nod to Nottingham SOS team, who allowed us to shamelessly steal the SOS title, which stands for supporting our staff. Next slide, please. Before I go into any more detail, I want you to consider these statements for a moment. It is okay to not be okay. Signs of acute stress are normal and should be expected during a pandemic. Most people who experience trauma in some form will actually positively develop from it. However, somewhere between 5 to 10% of your workforce, and I'm not just talking about clinical staff, will go on to develop mental health problems. Do you know how to find these staff? Do you know how to speak to them? And do you know how to signpost them? Next slide, please. The SOS team does all of these things, and our vision is simple. The SOS team is here to listen to you. We have worked really hard to become a single point of access for any staff member in distress for any reason. Now, admittedly, this means we do some signposting, but it has earned us a reputation as the go-to place for staff in distress. For me, this is a small but important part of SOS. It plays a vital role in staff feeling supported by the organisation. I believe the success of our team isn't the screensavers or literature we provide. It is putting faces to the service. It's going out to the teams, making connections and quietly helping. And then those individuals and teams spread the word for us. Next slide, please. So that's how we find them, but how do we support them? And this is where TRIM really helps us. Back one, please. We wanted something that was evidence-based, that would assure us that we were helping staff and not harming them further. TRIM, which is trauma risk management, comes from the military. It is well evidenced. It is a form of peer support based on a psychological risk assessment using a checklist. Trauma can be many things, and in COVID, it is often not a single clinical incident, but multiple incidents. It is PPE concerns, it's increased exposure to death and dying and moral injury, it is stress and anxiety. And it is this type 2 stress that is chipping away at all of us. It is constant and there's no let up in the near future. And use of the checklist can be adapted for this type of trauma that we are seeing during the pandemic. What I really like about TRIM is that it's bigger than just an individual. It has taught us how to manage bigger incidents, looking wider than just the individuals directly involved. We have very sadly had the death of a colleague here at Northampton, and the SOS team were able to support the organisation during that very sad time using the TRIM principles. Next slide, please. So remember, normally 5 to 10% of people involved in a traumatic event would normally be tiny, but this is, back one please. But this is a pandemic and we are all experiencing trauma in some form. So how many people is just 5% of your organisation? For us at NGH, a quick estimate of 5% is 390 staff members. This is a big deal for us all. We have a long way to go yet, and it is not too late to implement something like this in your organisation. Build a diverse team to reflect your diverse organisation. We have a multi-professional team of TRIM practitioners, including leadership at Gold Command level. You need to understand that different staff groups will have different cultures and you need to approach them differently. TRIM doesn't have to be a formal sit-down assessment, although that does work. It is peer support and it can be done over coffee as a normal conversation if you're clever with it. Remember, it is okay to not be okay. The majority of our work is reassuring people that actually what they are experiencing is normal and it doesn't mean that they cannot cope. Most of us will come out of COVID with emotional growth, but we must find a few that need a little bit extra support. Next slide, please. The final link in the chain is what to do with the minority that need additional support. We are lucky to have just employed a fantastic clinical psychologist who has supported us with understanding the clear pathways of referrals for the individuals. We have services available through occupational health, GP. We have a fast track into the IAPT service, which is an anxiety and depression service via our local mental health trust. Next slide, please. So finally, the SOS model can be easily duplicated. You don't have to use TRIM, although I would recommend it as it is evidence-based. The most important thing for me is that this is a personal service. Every single contact is made to feel listened to and valued and then not judged. And if you don't have anything like this in place, it's not too late. Thank you for your time.
Thank you, Moya. That's fantastic. I'm really sorry, in the interest of time, I'm going to cut my links a little bit. I have just put a comment in the chat. We're running about 15 minutes behind, so if people are able to create some time and stay with us, that would be amazing. Also, apologies, the slides are flicking around a little bit. We're having some technical issues, but I hope you're all managing to keep track with where we're up to. So without further ado, I'm going to hand over to Joe, who joins us from University Hospital North Midlands and is going to talk us through some of their changes across the urgent care pathways. Thanks for joining us. If you could put your camera on, that would be great as well, if possible. Don't worry if not.
Hello, good afternoon everyone. So I'll give you a quick whistle-stop tour of some of the changes that we made at the University Hospital of North Midlands. Some of you may or may not be aware we're a hospital split on 2 sites about 15 miles away from one another, the Royal Stoke and County Hospitals. We probably took a similar approach to many organisations, and if you can just flick to the next slide please, Charlotte. Whereby we had to make a number of changes. It was quite challenging for us because we had to do this at both our hospitals. We run 2 ED departments. We've got lots of urgent care routes into the organisations, and we wanted to streamline that all so that it was simple and easy making the changes. So we split both our emergency departments into red and green zones, resus majors and ambulatory care. We actually took out some of the activity from those departments with the support of our local walk-in centre. where miners moved to at the Royal Stoke moved to the local walk-in centre, and our county hospital miners patients moved to the fracture clinic. A lot of our ambulatory green pathways moved out of the ED department into either the surgical assessment unit, our ambulatory emergency care unit, or our AMRA. We run from our ED usually an in-reach service by our acute physicians, where we do a same-day turnaround, but we moved all of that out of the department to allow for split zones. We were quite lucky in that we have some infectious diseases consultants working in our organisation, and they were very supportive and helped us with realigning some of our wards. So we very quickly looked at how we would split our critical care units and all of our urgent care wards, so a lot of our medical wards, and we very quickly converted our infectious diseases unit and our respiratory wards into COVID red wards at the time. We identified between 500 and 700 beds across both sites where we could admit these patients to. We did some estates work, and I think generally that's what a lot of organisations had to go through, where we put doors on a lot of cubicles in the emergency department, and we're still using those now, and very grateful and wish we'd probably put more on, because we're forever making changes depending on what capacity is coming through. We did also relocate a number of services. So we did take children's assessment unit out of our ED. That went up to one of our paediatric wards. Alongside, the paediatric intensive care unit moved out to facilitate an additional critical care unit for the organisation, so we could split all of the zones for the critically ill patients moving through the organisation. Provided extra emergency theatres. We ran urgent endoscopy provision. And also looked at some of the other things that could be done outside of the hospital. So our GPs were very, very helpful, and they did a triage service so that they only sent real, patients. Of course, they're all real patients, but patients who really needed to attend the ED department. And they had some hot hubs that they set up so that they could see, patients who had symptoms and presenting there. The other things that we found very, very challenging were sort of operationally how we would manage everything through the hospital. So we redesigned all of our medical rotas, and the teams were really fortunate in terms of that there was really good communication between the clinicians. A lot of the specialty services obviously found themselves without any patients because of the reduction in number of attendances and elective work. So we made one rota for all of the junior doctors. We also got about 50 other doctors who joined the organisation from outside, who were on GP training and other training where they came to support. So that was really, really helpful. That allowed us to put additional doctors on our COVID wards. It also allowed us to run an overnight rota where they had dedicated doctors on those wards, because there was a lot of challenges for looking after those patients out of hours.
Sorry, Jo, can I just give you 1 minute warning?
Yeah, and then our teams then worked overnight as well. We had lots of challenges, and I think the next slide, you probably had many challenges yourself, where we were unsure of the demand that was coming through. We obviously had difficulties with some of our patient flow through the organisation because of the challenges of we didn't know what was coming next. And swabbing, we actually took the stance that we put every patient who was suspected into a size room. That did give us challenges, but we managed it, and we are still managing it now. And we had obviously the usual things like staff absence and self-isolation. What we did well, the next slide, Charlotte, was that we started preparing early, and I think that was really, really good for us. And we used a lot of our colleagues and clinical contacts and contacts around the country, and learnt from them. So earlier ED departments and earlier critical care units were doing things, and we're getting a lot of feedback. We made a lot of rapid changes, and I think, you know, people have alluded to that previously, whereby we didn't wait for a SOP and a policy to be ratified. We made the changes. We see if we looked at if it worked. If it didn't work, we just went back to it. We redesigned it continuously, and took quite a good approach on that, really. And we had a lot of support in the hospital at trust board level and through the divisions and directorates, and a lot of our clinical teams were so engaged. They just stood up to the challenges. They came up with the ideas, and we shared those ideas across the organisation from ward to ward. That was really, really good. We obviously got quite a lot of support from our social partners. We were normally running with high proportion of medically fit patients in the organisation, around 80 up to 100 at times, and that reduced down in the medical division to about 20. So that was really, really helpful, that we managed to get a lot of patients out and to their own homes. And obviously the Birmingham were very supportive towards supporting paediatrics. I think the main thing now really is for us is the road to recovery and what our hospital looks like going forward. We're still continuously changing, and again we're making ward moves and changes things every single day. Just whilst we're bringing other services online, our attendances are increasing, and our pathways, we're finding new pathways for things every day.
Thanks, Jo. I'm really sorry, I'm going to have to cut you off. That was really, really interesting. We're just running fast out of time, but I'm sure lots of our acute sites can reflect on a lot of that. So thank you so much for joining us. We're going to move over to Chesterfield now. And Chesterfield, I think Claire's doing both presentations. The first one looks at the voluntary sector, and we had St John's talk on our event yesterday, so that's fantastic. And then moving on to the use of palliative care in ITU. So Claire, I'll leave you to your slides. Thank you.
Okay. Can you hear me okay, everyone?
Yes, thanks. You're coming over fine.
Okay, so good afternoon, everyone. I'm going to talk to you today about two things that we're really quite proud to have been involved in during COVID-19. And the first one was around our St John's volunteers. So as we all have been under the challenges of staffing and looking at different workforce models through COVID-19, we were involved quite early on with a memorandum of understanding which was sent out by East Midlands around what St John's could offer to the Acute Trust during COVID-19. Initially, when you looked at the memorandum of understanding, it looked like it was predominantly discharge, but when we delved into it a little bit deeper, as we started to talk to St John's, it was more about actually they could bring quite a lot to the emergency department. And with the increased stretch that we had with our staffing and skill mix, we thought it was a good opportunity to start building some different partnerships that would hopefully carry on after the pandemic. So it took a while because, like all NHS organisations, we are slightly risk averse around DBSs and checks, but actually the memorandum of understanding was very defined on what they already had in place, how they were being managed through St John's Ambulance. So actually we fulfilled all those criteria, and St John's had also sent their volunteers to a 2-day additional training course about caring for patients in a hospital setting during COVID, because St John's skill set is normally around events and managing first aid and assessing and then moving patients on to where they need to go rather than caring for them in a hospital setting. So we implemented the MOU, we started the volunteers within the emergency department. We, like many places, had flipped to a red and a green streams for ED. We had a 7-day, 14-hour rota with volunteers working in both green ED and red ED. They were upskilled, additionally to the skills they already had, to undertake some of the other key tasks in ED. So they did give simple medications, they took OBS, they were involved in some of the initial triaging in ED, which helped free up some of our clinical staff to focus on other areas. They very much were brought in to support operational flow, and there was an element of, as mentioned by some of the previous presenters, relatives were very much left at the front door. So you'd had somebody who had either had a life-changing event or needed urgent care services, but once they'd had that initial triage by our streaming service, the relatives were sent out of the trust. So we looked at them for providing some wellbeing and emotional support for patients as well, where those patients would have normally relied on that from their families. Really positive learning outcomes from this. It's absolutely a great example of how different health organisations and voluntary and health can work together to help patients and also colleagues across our organisation during this pandemic. It increased the numbers of staff in ED. It allowed more time for staff to take out of the red ED, to come out of their PPE and have some designated time.
Give you 1 minute warning on this one, Claire, please.
Yeah. They obviously added resilience, and we are hoping the partnership will continue. There are plans with ourselves and St John's Ambulance following us retracting out of our pandemic escalations for them to support us on a Friday night and through the weekend. The staff have embraced it. The volunteers are now part of the team, and we are also looking at whether we can improve on some of the skills that we have upskilled them with. So there's some work going on about what else we can do with them. But it's a really good example of how using the voluntary sector in a totally different way can support acute trusts during a pandemic.
Thanks, Claire. Do you want us to move on to the next ones? I know you're kindly speaking twice for us.
Yeah.
Thank you. Sorry to rush a bit.
No, it's fine. So this is around palliative care counselling. This came about following a discussion on our strategic discharge calls in Derbyshire, where the hospice were offering to support us if we had patients with tracheostomies that needed to come out for longer term care during the pandemic. And this was based on what was being fielded from London. We didn't have that need at that time, but actually the team had a skill set that we really needed within our intensive care areas and our COVID positive wards. So what Ashgate provided was a cohort of their supportive care service, and they attended on site, supported the ITU teams and the COVID teams with some one-to-one counselling and also some group counselling. They used a face-to-face and a peer support model, and the facilitators were trained in clinical instant debrief interventions, and it was within a safe space. Really positively received, because we had a lot, as with other organisations, a lot of staff that had either worked in ITU previously and needed reskilling, or staff that volunteered to go into the COVID-19 ITU areas with no experience of what that looked like, and how to support patients and families when they weren't actually able to see each other during this time. The staff emotionally supported it at this time of crisis, and they were coming close to burnout when we implemented this. And we've now acknowledged as a trust the need for longer term options to be explored as part of our health and wellbeing offer to staff. Because of this, they've been able to continue to deliver their quality of care, and they've adapted really good coping strategies which have been learned. And we also widened it to patients and their families as well, which had a very positive impact from that perspective.
Sorry, Claire, can I just give you 1 minute on this one as well?
Okay, no pressure. So we've continued with the service. The patients have continued to receive the care that they needed to, and the staff in those areas speak openly on all our forums of feeling valued and positively supported during this period. And actually, it's made the teams across the trust a lot more resilient and have made the teams closer. So it's been a really good forum and a really good use of, we couldn't use the hospice beds, but we've been able to ask their staff to support us in a different way.
Thank you, Claire. That's really great. And I'm so sorry to all the speakers that we are rushing through a little bit. I think there's some questions in the chat for you, and please, people, use that as an opportunity to get some learning from all these fantastic speakers. There's a few questions actually still waiting to be responded to. So I'm not going to whittle on, but I'm going to hand over to South Warwickshire, who are going to look at managing the patient for us. So Rachel, thank you for joining us.
Hello, Charlotte. Hello, everybody. I'm Rachel Williams. I'm the Associate Director of Operations for the Emergency Division over here at South Warwickshire Foundation Trust. If I could have the next slide, please, Charlotte.
It's on, Rachel. I don't know if you've got a bit of a delay, sorry.
Okay, I have got a delay, sorry. Okay. So when this happened, I'm sure everyone on the webinar thought, how on earth are we going to manage this? And we set up daily silver commands for key decisions, pathway change approvals, and also access to senior team members. But operationally, what were we going to do to get the patient in the right place to maintain staff and patient safety, to reduce spread of the disease, and also implement the agreed changes at pace? If you could change the slide, please. What we did at South Warwickshire, we spoke with IT and we set up our COVID rainbow, and this changed as did the guidance for swabbing. So it was designed to go on the patient tracker. So as soon as the patient hit an assessment area, ED, AMU, frailty assessment, that we knew what the patient was. So the blue, well-known, loved COVID splats is what we call them. So the blue suspected was patients with symptoms. So we knew that they had to go to a blue area. The COVID splat changed to red when we got the positive results. The negative results were green, and the suspected yellow splats were for those asymptomatic patients that we were testing, because we had to test everybody as we went through. What we were really lucky to be able to do is when our results were pulled through from Lorenzo, which is our patient tracking system, the splats changed colour. So when we were looking at our patient wards, what we could do is we could make sure that the patients were put into the right place at the right time. Next slide, please. We then, as a team response, thought, right, we're in this together, and this is what most people do. This is a picture of Rose, who was our 100-year-old birthday that we celebrated with her as her family couldn't join, and we read and sang happy birthday to her. But I think the most important thing for us, and I'll speak really quickly as I know I've only got a few minutes, was to have good oversight and situational awareness. So what I'm going to talk about is our emergency boards, why they were there and how we set up this to help with our SITREP reporting, to help with early escalation and support from other areas. In order for us to do this, and I've got some examples that will come on in the next few slides, is we doubled our site management team, and we also put a mid-shift in, and that mid-shift was there for resilience to make sure that we'd got somebody to stand in should any of our staff go off sick. Next slide, please. So everything was up electronically, but the hard thing with electronics is you have to click into different systems at different times to be able to pull those boards up. So we soon turned our site office into a control hub, which had whiteboards all around the areas for us to be able to update everything at the same time. This achieved us to have trust oversight at any time, knowing how many patients were waiting results, how many we were there caring for in the right place at the right time, and also to act on swab turnaround, trends on numbers coming through, and enabled us to help open the right capacity at the right time. We also looked at, next slide please. ITU capacity, to make sure that we knew where the patients were for ITU, whether we were going to need to go into surge capacity, and also we charted our mortuary and our deaths on a live basis. The mortuary capacity, because we are the community mortuary for the area as well, enabled us for early escalation to be able to support the STP as well, and also to look at whether we would need the Birmingham mortuary at the airport. Next slide, please. This is one of our wards that we've got up, and Mary was our CPAP ward. So we wanted to check, to start off with, what areas were our best airflows and what were our best...
1 minute, sorry, Rachel, 1 minute.
So this is where we've charted everything down. You can see the crosses there are for social distancing. Next slide, please. Again, here we've got up nursing homes. So we shielded our nursing homes in side rooms, and also our shielded patients went into side rooms. This shows that there's huge demand, and we will be able to move the patients into the right place at the right area. You can click onto the next slide, which just shows yellow. And then our next slide shows the impact of what we feel to have live, next slide as well, to show that we had live situational awareness, to be able to use our capacity and planned opening at the right time. We feel that this has helped us reduce our risks to staff and patients, to enable flow and cope with demands going through the doors. The next slide is just to show that actually we stayed really well and green in most of our areas. Next slide is our length of stay, which shows our 7 and 21 day graphs, and where there's a slight peak on the 7 days was where we were waiting for our care home swabs to be 48 hours before discharge. And then the next one is one of our happy team, which are socially distancing, which helped with our flow.
Thank you so much, Rachel. So we canted it through a bit at the end there, but South Warwickshire have done some amazing work. We recognise that, and it's really lovely to hear that and see that visualisation. So thank you so much for sharing it. We're now going to move on to the Robert Jones and Agnes Hunt, which might seem a bit unusual as they're not one of our urgent care units, but they've done some really great work around capturing lessons learned, and we thought this was a real opportunity for all of you joining to understand how you can do some of this work moving forward. So Stephanie, the floor is yours for 5 minutes. Thank you.
Hello to everyone. So my name's Stephanie Wilson. I'm the Performance Insight and Improvement Manager at Robert Jones and Agnes Hunt Orthopaedic Hospital. If I say next slide now, hopefully it will come up as I'm talking. Oh, great. I'm just going to run through really our lessons learned approach and our proposed approach in our trust to learn from the impact and responses made during the pandemic. And during these next 5 minutes, hopefully less if I can catch up some time, briefly explain it as the why, the how, the themes, and the feedback and support in terms of how that approach works. So next slide, please. So the first one is obviously the why, and I think all the slides we've listened to so far have really covered that, in that we've done so much, whether that's working from home, use of virtual technology, changes in our clinical pathways, how we monitor PPE and the requirements there, and how we've supported staff and patients. The list really is endless in terms of everything we've had to do in responding to this pandemic. And the approach that we're trying to do and the methods we're using is in terms of, we want to know what our staff and patients want to cease, in terms of we want to let go, what we want to keep and accelerate. So things we've actually done that actually has really added value, and we want to somehow keep that, sustain that, and even evolve it further. And then what would we restore and redesign? So simply put, what would we adapt, what would we adopt, and what would we reject? Next slide, please. So this first slide is really just, we started to look at what systems we already had in-house in our hospital, rather than reinventing and adding more work in the system. And we were fortunate enough, we had an ideas portal which sits on our intranet. All staff can access. It's very transparent and open. So whatever idea gets logged in there is visible to everyone. The questions it asks is very simple and actually fits well in terms of the approach for COVID learning as well. So it asks who's submitting or who are they submitting on behalf of, the core purpose it's aligned to, so our trust values and goals. Is it caring for staff, caring for patients, caring for finances? Is it all of them? The idea and the problem or the opportunity it will address, and almost a bit about empowerment as well. Does it need approval to be implemented? And documenting who the idea will affect. The bottoms of the slide, you'll see how it links in with the publication from NHS England that came out on the, I think, middle of May, around building local learning systems to capture and share best practice that supports for peer review. It's one of the recommendations within that framework. So this quite literally is a system, but it's certainly a system that's already established in our trust that staff have confidence in using, and it's simple to do. Next slide, please. So that obviously looks at how we capture staff learning, but obviously we can't, it's not forgetting the patient feedback. So what's been captured from our patients, the Attend Anywhere questionnaires, what's still been going through our governance teams, published feedback as well. There's so much out there, not nationally, but also internationally. So, you know, we've been linking in with our library teams, which is what that image on the slide is about. So our library team have been coordinating, highlighting to us the publications as they come out around lessons learned, but also we want the system feedback. So we want feedback in all forms and all shapes, and knowing that everything and everyone counts towards this. So I suppose the next thing to ask, and if I say next slide now, is around the themes. So how would you even go about coordinating all that feedback that staff are giving, patients are giving, and is coming from publications? Well, rather than reinvent the wheel, we've actually used, and I've put the link on the slide, an Evergreen Health Group publication. So Evergreen Health, where they documented their critical early lessons learned from their experience managing many of the first COVID-19 patients hospitalized in the US. So, you know, they are the themes that we've drawn out from there. We're not recreating that. And that publication gives you examples that fit under that themes as well. So no stone unturned approach. Next slide, please. So we've gathered it all, you know, we themed it, and actually then it's about the feedback and support. And this is about, again, it's how we embed this in our existing committees and structures around lessons learned, our continuous improvement approaches. We make sure it's linked with our performance reports, because actually, how do we know it's an improvement if we can't measure it? So, you know, what is our performance telling us on a trust on the ground, qualitatively and quantitatively? Facilitated conversations, we've made sure there's support there. Obviously, this is the aim, that there's always weaknesses to improve and strengths to sustain. So it's a very positive approach, because we want the honesty to come back from these conversations and learning. Next slide, please. Okay, it's not come up.
It is there.
Is it there? Okay,
yeah.
So this is my final slide, and it's just explaining the journey that we're all going on. It's a focus of continuous improvement. It's that continuous, we're looking at what we're doing, we're studying at the effects it's had on patients, staff, the wider system, the population, and we're looking at how we can always further improve. And that is the whistle stop tour. Thank you.
Thank you, Stephanie, and apologies for rushing. For those of you that are able to hang on, it would be amazing. For those of you that aren't, obviously this is recorded, so you will get a copy of it. But Diana Lacey, who's the Director of UEC from London, is very kindly joining us now to talk about their journeys. Obviously, they've been a little bit further ahead in all of this than the Midlands and all of the other regions. So I'll hand over to Diana to talk about the restoration elements from London. Thank you. Are you there, Diana? I know Diana is there because she's texted me.
Can you hear me now?
Yes, thank
Better.
you.
Right, finally. Sorry, I've had a few issues with this Teams thing the last few days. Okay, Thank you very much for inviting me, Charlotte. And as Charlotte says, I'm the Regional Director for Urgent and Emergency Care in London. And what I'd said to Charlotte I would do was talk to you about where we are now. So rather than a backwards look, start to think about what it is that we're going to do next. So if we go on to the next slide, please. So this is, we're very familiar with you. This is the kind of the picture in London. But it'll be very much the same all over the country, and it just shows what happened in our departments over the COVID period. We have got 28 type 1 ED departments in London, and we have varying abilities, but like everybody, what we saw was that rapid drop in patients attending. So we can go on to the next slide, and a rapid improvement in our performance against the 4-hour standard. We've now got 2/3 of hospitals in London still meeting the 95% standard, which if you told me 3 months ago, I would just not have believed you. What this does, though, is show you what happened to the rest of the system in, well, the 999 and 111 service, whilst all those patients weren't coming to ED department. Those green bars are the attendances at our ED departments. And the orange line that goes across the chart is the calls that went to our 111 service. And you can see that they peaked out at about 160,000 patients. We normally see around 8,000 calls a day to the service, and peak COVID was 25,000 calls a day. Absolutely massive increase in the volume of calls, and because of the way the telephony system works with calls diverted across the country, not only did we nearly take out the telephony service for the country, but we also meant that it was incredibly difficult for our patients, because somebody taking a call in a different part of the country clearly can't get the patient back onto the right pathway. So not really terribly helpful. And if I was to give you a call for the ambulance service, you'd see a very similar picture. I'm sorry, we have the next slide whilst I'm talking. A very similar picture with the 999 calls going through the similar hike in activity and really long response times for those patients. But whilst all those patients weren't coming to our department, of course, there's a whole group of patients that we would much rather have been there. And when we looked at this nationally, so this isn't my work, this is some work that the national team have done, we started to try and work out who were the patients that could probably more appropriately have gone to be seen somewhere else, but to try and understand who were the patients that we actually needed to come to the department. So there's missing patients, and you can see the ratio is about 1 to 15. I think Charlotte will share some of these slides later, so I'm not going to dwell on it, and we'll, given the lack of time, let's go on to the next slide. So just as a brief introduction to think about where we're going to go in London next. Clearly, we have to be prepared for a second surge. We don't know what is happening or what might happen. We do know from this morning's incident report that the R number is now increasing again, but we also know from our planning that we expect to have a second surge at some point later this year. Not quite sure when, not quite sure whether it will be quite as steep as last time or more gradual, but we do know that we're going to get a second surge at some point. And I just remind you that for us at the peak of the COVID point, we were doubling ITU capacity every 24 hours. So it was a very, very, very steep curve. And we clearly need to be prepared for that. And we have to have the 111 and the 999 service prepared. But we also, like some of you have already commented, are starting to see patients return to departments, and indeed we want the public to know that the NHS is safe and they can come to our departments, but that does mean we've got to start thinking about how we minimise the risk of infection both in the departments and crucially, with the numbers increasing, practice social distancing in things like waiting areas. And we clearly can't have patients, as we have had in the past, not that any of us wanted it in the past, but we can't have ambulances queuing. I can't have a crowded ED department, certainly can't have a waiting room with people sitting on the floor because there are not enough chairs to sit in. And we really don't want patients waiting in corridors for admission to a hospital bed. So we've gone to the next slide. And really that just emphasises my point that this has to be, never ever was acceptable, but it really in a COVID environment where patients are going to become infected cannot be anything that we return to in the future. Next slide. And the next one, please. So the first thing that we've done, and we've worked through our gold command, is ask people to go back to some work that we did, and I think many of you did last year, and we often do at the start of the winter season, and is to look at what the escalation protocols look like, what full capacity protocol look like. When we look at those sorts of protocols, ordinarily, they are often based on time. So escalation will be because a patient has been in the department for 2 hours or 4 hours, and sometimes it's because we haven't got bed capacity. What we don't ever do is think about waiting areas and the need for additional waiting areas or additional waiting space. And I think in the new world, we need to start thinking about escalation on a basis of capacity rather than time, because the focus is trying to prevent infection. So we've asked all of our STPs, or our integrated care systems now, to go and refresh those, and we will have a peer reviewing event next week so that we all look at some, I hope, areas of really good practice that we can share with each other. Next slide, please. This is where the big focus, though, is, and this is going to be all about thinking about really those patients that didn't come to our ED department, that we would prefer that go somewhere else. So that's that 14 of the 1 in 14 patients when we did the assessment that we think could be cared for somewhere more appropriate than an emergency department. We don't have it on the slide, but the first thing that we'll be doing is looking at our ambulance service and at the hear and treat and the see and treat, to see whether we can't reduce the number of patients that are conveyed to an ED department. Those figures changed dramatically during the COVID period. They're starting to go back up again, or down again, I should say, it's the other way around. And we want to see what we can do to maintain the good practice that we were seeing during that incident. The second piece of work, though, is something that's now being talked about nationally, but was something that we've been talking to the national team about for probably the last 6 to 8 weeks. And that is starting to think about how we make better use of the 111 service, and people encourage public to use the 111 service rather than or before they go to an emergency department. It's had various names. We've heard people talk about talk before you walk. You'll hear people talk about think 111 first. The current being called help us help you, but I've no doubt that will change again as this develops further. If you focus on the left-hand side of the slide, first of all, that is the bit where we're very focused at the moment, and this is all about getting the basics right. We can't be encouraging the public to phone 111 before they access emergency departments if 111 is not fit for purpose. And I talked before about how that surge in demand was really, really difficult to manage. If we're going to talk about using 111 as a first point of call, so to speak, it has to have the capacity to take the calls, not only that we're going to be redirecting, but all the calls that we might get in a second COVID surge. So we're spending a lot of time at the moment looking to ensure that we've got the right capacity in those services. But as well as that, we want to have the right clinical capability in the services as well. We currently validate about 50% of those referrals to an ED department before the patient is sent to ED, but by all means, none of them are validated. And when you audit that data, there is no doubt that a significantly greater majority of those patients could actually be redirected either to their primary care, to their GP, or to the urgent treatment centre, and we would not need those patients to go to the emergency department. So a lot at the work at the moment, increasing both the workforce capacity overall, but also looking at the clinical assessment service to enhance that as we're going forward, and doing that in very different ways. Like a lot of people, we include GPs, but we now also have paediatricians and multidisciplinary teams, particularly looking at frailty pathways based in our CAS service, and we'll go on to develop that. Over and above that, we're now starting to look at having made that assessment where the patient goes to. So we already directly book into primary care, and we already directly book into our urgent treatment centres. And we are fortunate we have an urgent treatment centre almost at the front door of every A&E department in London. But we don't directly book into all of the services. So a big piece of work to ensure that we have the capacity to book into the services, because again, if the patient's phoned 111, all we do is say, oh, you need to pop along to ED, patients are very quickly going to stop accessing the service and we won't have sorted the problem out. So lots of work sorting out the capability, lots of work sorting out the capacity, and then strengthening those pathways that already exist into primary care and the pathways that exist into our urgent treatment centres. And then separately to that, we're now starting to develop ways in which we can book into other services. So you, like us, will have been developing lots of SDEC services over the past years, and but most of those are not a direct referral. Often the service is almost at the back of the ED department. The patient still comes through the front door of ED to go to that service, and we're looking both about how we make those electronic referrals directly from a 111 service, but we're also looking geographically to see where those services be, and quite radically, some of them in future will not be in a hospital setting. They will be off-site, and certainly some of them will not require a patient to go through an emergency department to be seen. That would include things like, for example, mental health services as much as physical health services. And then the most radical one of all, perhaps, is how we make referrals into an emergency department. As at the moment, of course, if a patient is referred to 111 or is advised to go by 111 to go to the emergency department, that isn't a formal referral process. But given that we are dealing with a lot of patients with long-term conditions, a lot of very vulnerable patients, when you think about that group of patients that didn't come to ED when we perhaps would have wanted to in the incident, who want to come back, we do need to be able to herald the patient into the department. At the very least, we need to let them know that the patients are shielded or not shielded. And what we're looking for at the moment to see if we can not necessarily book, but have time slots that those patients can go into. So the patients would come within maybe a 2-hour window so that we can manage the flow of patients into the emergency department. Can you on to the next slide? Yes, we probably don't need to dwell on this. It's just sort of setting up the governance of how we're going to organise this. This is our governance for the whole of the London region. And really what it's designed to show is how important it is. So we have a strategic oversight group at the top, and we have a number of advisory groups that advise on issues to the recovery group. You can see they're generally made up of particular groups of patients, so that of staff. So there's a clinical advisory group and there's a chief execs reference group. And then what you see at the right-hand side is two pieces that are not about people, they're much more about particular issues. There's a Nightingale Advisory Board and a UEC Transformation Board, which give you some idea of the significance that we are giving this in London at the moment. Right there up at the top is probably one of the most important things we're going to be focused on for the next 3 months. That was quite a quick canter. I hope it all made sense. I'm more than happy to answer questions now. Or Charlotte, if it's easier, if you want to click the questions up and send them in an email, and I can answer them and send some answers back to you at a later date.
Thanks, Diana. We will, and that was really informative and so important for us in the Midlands to start that look forward. So thank you, and I'm just going to hand over to Jeff to close now. But thank you for that.
I said that the whole thing's been really fascinating, and I love some of the stuff in Northamptonshire in terms of the property drop-off service and using the iPads and the volunteers, and also the St John's ambulance stuff, and some great stuff in Swift as well. That's just a canter through them. So thanks everybody for bearing with it. It did run over slightly, but that was because we packed so much into it to get as much across as possible. And have a good weekend and a safe weekend. And thanks to all the speakers for their contributions. It's been brilliant. Thank you very much.
Thank you.